Our next speaker is Dr. Levitt. I've known Mike Levitt for quite some time, as you will probably recognize him, as he has spent a significant portion of his life roaming the halls of HARBORVIEW, taking care of brains, and sick brains in particular. He's now an assistant professor in neurological surgery, and he's one of those cool kids who not only can cut open your brain with a knife and a suction, but can also drive around the inside of it using endovascular techniques, which is the future. And he's got some great cases to talk about those big strokes. I don't know if you remember last spring, before your summer vacation, Dr. Sayer gave a great talk about maybe the evolution of stroke care, and that big proximal acute onset strokes may be more salvageable than we have thought in the past. And so we asked Dr. Levitt to come show us some examples and walk us through what he does. Thanks very much.
Thanks, David. Can everybody hear me? So thanks for the invitation to speak. It's a pleasure to be here. So yeah, I did my residency training here at HARBORVIEW, and this is sort of my home, and coming back here as faculty is good, so I recognize a few faces. But I'm going to be talking to you about endovascular clot retrieval for ischemic stroke. You know, you've heard about this a little bit before. This is one of the things that we do here at HARBORVIEW that we're really proud of, and something that I think makes a big difference to patients and like I said, can be back from the dead. And that term actually applies in more than just the literal sense. So I have no disclosures relevant to this. So back from the dead, what we're talking about here is both bringing patients back from what seems like a life-threatening stroke, and then also the idea that originally putting a catheter up into somebody's brain from their femoral artery, pulling out a blood clot, taking it out, reperfusing the brain. At first, the big trials, they didn't work. And so everybody said, well, endovascular treatment of stroke care is dead. But subsequent trials have shown that actually works very well, which I'll show you. So that's why the treatment itself is back from the dead. So it works on a couple of levels. So it's always good to start with a case. So this is a case that was relatively recent, about 8 or 9 months ago. 59-year-old with acute left-sided paralysis and slurred speech. He was basically eating breakfast and had trouble suddenly with talking. Still able to eat some cereal while he talked to his wife. And they brought him to the emergency room. A CTA was done that shows a right MCA occlusion. So here's a coronal view of the CTA for those who aren't familiar. The carotid artery is here. This is a normal middle cerebral artery, and this is where the middle cerebral artery ought to be, but it is not there. And you can see there's something missing there. So he underwent a CT perfusion, which is a little bit of an advanced imaging technique that we do here at HARBORVIEW. This actually shows how well the blood is getting to the brain and the speed at which it traverses the brain itself. So this is what a CT perfusion looks like. You can see that this area that's dark, you don't have to know the physics behind it to know that it's not good. But this is an elevated, what's called mean transit time. So blood is taking a very long time to get through this portion of the brain, mostly because only a very little bit is getting in. And we also see here is another look at a different type of perfusion. This is called cerebral blood volume. Basically, this shows that the tissue in the brain right now is not dead. Even though there's an increased amount of time that it takes for the blood to get there. The highway, there's like a few lanes closed on the highway, but there's still traffic getting through. And that tells us that there's some salvageable tissue, meaning if we can open up that blood vessel quickly, then this brain will not actually complete a stroke. We can actually reverse the stroke. So we took the patient for an angiogram. You can see here, this is a straight on view. You can see that flash of what the skull looks like to give you an orientation with the eyes up here. And here's the carotid. And you can see that there should be something here. There's a cutoff there where the middle cerebral artery ought to be. So the next thing we did, and I didn't film this myself. This is not actual patient. But we use this technology where we bring a catheter up to the carotid, which here doesn't require cutting open the vessel for you to see. And then we snake a little micro wire. This is about a 0.014 inch micro wire, so really small. We can actually go through the blood clot with this little micro wire. And this allows us to get kind of like our own highway where we can bring up instruments. So a little microcatheter that we can bring across the blood clot. And we can basically get to the point where we can do something to the blood clot. Now, many people have tried many different ways to break this up. You can hook it up to a vacuum and try and break it up into little pieces and pull it out. You can grab the clot by just putting a catheter inside it and taking a syringe, making a suction with the syringe and pulling the whole thing out all at once, which sometimes work. Or there's this technology, which is also really actually very good, where you basically put a little stent, which is a little metal tube that you can use in the heart. You put a little stent across the clot, and you basically mix the stent up with the clot, get it tangled up in the stent like this. Then you can drag the stent with the clot back into the catheter, and you can pull the whole thing out. And this was actually discovered by accident. Somebody was trying to stent open an acute occlusion and couldn't get the stent to detach, and just dragged it out and opened up the artery. So sometimes, better to be lucky than good, right? So we can pull the clot out through this catheter, and it usually comes out in a big chunk. You can actually see it if you look on the back table. And then when you finish, the blood vessel looks like that. So this is what we like because the patient had immediate resolution of all but a little bit of dysarthria. And what's amazing is we do these patients awake because we don't want to waste any time with putting them to sleep if they're not already asleep. So the guy's sitting on the angio table. He can talk, he can understand what's going on, but he can't move his left side. And we do this procedure, we pull it out, we shoot that angiogram, and then we say, hey, can you squeeze my hand with his left hand? And he's like, hey, like everything's fine. So truly back from the dead. They call it the Lazarus effect. So we see patients who come in and they really are at death's door. They're not responsive, they're barely moving anything, and then if you pull this out, depending on the patient, you can reperfuse the brain, they immediately get better. So it's a very, very quick, very gratifying procedure. Feel free to ask questions.
Do you alter their arterial pressure, or is there an advantage or disadvantage to having a high blood pressure versus low?
This is a great question, very detailed. So the question was, do you alter the arterial pressure to bring the pressure up or down? The sweet spot is between 140 and 180 systolic. The limit of 180 is because if patients get too hypertensive, they can cause bleeding into the area that has a lower perfusion. There's more fragile brain tissue. And if the blood pressure is too low, then whatever little bit that's getting through, the little traffic that's going through on the lanes that are mostly closed, if it's slower, the traffic doesn't go as quickly. So if you can, 140 to 180 is good. What we really want is to avoid hypotension. So those numbers aren't exact, but it's a great question because that's one of the things pre-hospital that's really important. Do you have a question?
Could you speak about time of onset to point of...
Absolutely. It's like did we work this out beforehand or? Okay, $5 for setting up my talk, but I will get to all that. Yeah. So this guy went home without deficit, and he's really happy. So my talk is really about how clot retrieval works, and there's a caveat there, and that's because timing is everything. And the reason I'm speaking to you guys is because you provide the timing. You are the critical link in this chain. So timing is everything, and identifying stroke in the field is the reason that I'm talking to you, and we can't do our job without you guys doing your job. And you guys doing your job well makes our job really easy, and everybody likes to have their job made easy. So identifying stroke in the field, and then high volume stroke centers that have the ability to do this procedure, which not everybody does, at any time, 24/7, 365. This is obviously a setup for better outcomes for the patients. So we'll start by talking about how clot retrieval works. So remember how I told you there were previous trials that said that it didn't. So those trials in 2013 were basically older technology, pretty poor patient selection. They just weren't great trials. And they didn't really show a difference between IV-TPA, which is a standard of care, and IV-TPA with endovascular clot retrieval. New trials, 5 of them now, with hundreds of patients that all got published within a very short period of time. I guess everybody was really busy. Showed that there was improved outcome with endovascular thrombectomy, which is that technique I just showed you, or EVT. And that's in addition to or without IV-TPA, even for patients who are not eligible for IV-TPA. For instance, they've had recent surgery, or they have a little bit of bleeding, something that would contraindicate giving them a big clot-busting medicine. It still improves outcomes. And the previous 3 in 2013 did not show benefit, but that was because, like I said, the design was flawed. See, what we do in neurosurgery, as with most people in medicine, is if we don't get the answer that we want, then we just blame the people who did the study the first time and say, you didn't do it right. I believe that it works, and my faith is more important than your data. And everyone, you laugh, But
You're
every,
right in here.
right?
Bring back the light
I
again.
feel very strongly. But every once in a while, there are legitimate design concerns, and when those concerns are addressed, or the technology gets better, or in this case, a combination of both, then we can actually get it right. So this was an example of a trial that showed us how not to do a trial, and then we were able to, in multiple different countries, in multiple different trials, show that it actually worked well. So these are everybody has to have a cool acronym for your trial. You can't have a trial without an acronym. So Mr. Clean, Escape, Estend IA, Swift Prime, Revascat, which was a Spanish one, and they all showed they're multi-center randomized trials of patients with large vessel occlusion, so big carotid branch vessels that were blocked by a clot like that one that I showed you. And that was the standard of care, which is IV TPA, versus IV TPA and endovascular clot retrieval. Or in some cases, patients who were beyond the 4.5 hours limit from onset. When we talk about time limits, there's a limit to when you can give IV TPA of about 4.5 hours. The original trial showed a benefit before 3 hours of onset. Another trial in Europe showed that you could extend the window to about 4.5. Anything past 4.5, it's unlikely that the clot-busting medicine will actually break up the clot. The clot's going to be too organized to open it up with the drug, so you're not really supposed to give it after the 4.5 hours. And for endovascular, we actually showed that it's within 6 to 12 hours of stroke onset. We still had good outcomes. Now, the majority of the studies showed less than 6 hours, and most endovascular surgeons that you'll talk to would say that less than 6 hours, you almost always want to go for it. Over 6 hours, it's questionable whether you can do it, although we've seen younger patients 8, 12 hours out that, again, have really good outcomes. And this used that stent retriever technology, which I just showed you, and the primary outcome was modified range. So it's basically whether they're independent at 90 days, which is what anybody cares about, right? We can make the scans look great, but it doesn't matter if the patient's still in a nursing home. And so this is a busy slide because this is all the trials, but the important thing is that the 90-day functional outcome for patients who underwent endovascular clot retrieval, you're talking about 2.7 times, 3.75 times the just IV TPA alone. And so basically what we're seeing is the number needed to treat of 5, if you put all these together, like this. What that means is, here's a plot of all of these trials and then a composite of their outcomes. This is, space over here is the medical management, just TPA alone, and over here is interventional therapy, clot retrieval. You can basically see, you don't have to understand the statistics to see everything is over on that side. What we're seeing is a 2.42 times odds of having a good outcome, meaning independent at 90 days, compared to not getting clot retrieval. So what this shows is that if patients are eligible, they really should undergo this treatment, because overwhelming likelihood is that it will help. And when you talk about number needed to treat, that means that for every 5 patients that undergo endovascular clot retrieval, 1 will have a better outcome than not doing anything at all. That may not sound great, but actually we do plenty of things that number needed to treat is 50, 100, 150. So it's pretty much worth it. If it were me or my grandmother, I'd probably want it, right? I mean, low risk, high yield, sounds good. So clear improvement in functional outcome. This is one of the plots from one of the major trials in the New England Journal. And what I want you to look at is, these are modified Rankin scale. Basically anything above this, anything this color or above is a good outcome, meaning independent at 90 days. Anything lighter shade is poor, and then this is death. And this is the interventional group. This is the group that didn't receive an intervention. What you see is, and this is percentages, so in the control group, no patient had 0 symptoms, meaning no patient went back to completely normal. In the interventional group, 3. In the interventional group, 9% versus 6% that had a very mild disability, and then a substantial amount that had a mild to moderate disability, but were still independent in 90 days. This shift shows how much better interventional treatment is. You can see substantially higher percentage of patients that were independent at 90 days with endovascular clot retrieval. I'm not telling you this because this is, what I do for a living, although it is, but because, this is a really clear benefit of this treatment, and this will become, I think, the standard of care for eligible patients. I mean, it should. So there's your difference. So the conclusion of the trials, which again, if you look at all the data, is that it's the best stroke treatment within 6 hours of onset for large vessel occlusion stroke. But patient selection, improved technology, and speed are the keys to success. And this we talk about speed. In another study of 193 stroke patients, if you did that clot retrieval within 90 minutes of CT, it was a 50% improvement in patients with good outcomes. So this is a real effect. The speed has a real effect. The clock starts when the patient's symptoms start. Now, if they're out in the middle of nowhere, the best we can do is the best we can do. But if they're close to a stroke center, then we have a real opportunity to impact their outcome in a really positive way. And that comes from first, identifying if the patient's even having a stroke. And that's what I'm going to talk about next. So clot retrieval works. Timing is everything. Identifying stroke in the field. This is the key of our timeline. So how do we identify stroke in the field? Well, there's a couple of different pre-hospital tests that we can use. The one that you see all over in the billboards and stuff, American Stroke Association, they talk about, is the FAST, which is the face, arm, and speech test. And so this goes with a facial droop, right? An arm drift, so you have the patient up here and then drifts, and speech problems. And when you use these three together, if they're all three are positive, then the paramedic diagnosis of large vessel occlusion stroke is correct 79% of the time. That's really good, right? We love tests that are, chance is 50. We love tests that are better than 70%. So this is a pretty good test. Can we do better? Well, the one that people talk about a lot now is the LAMS, which is the Los Angeles Motor Score. And this is very similar, but if you're going to pay attention to one, this is the one to pay attention to, because I think this is better. And it's very easy. So it's a series of points, right? 1 point for facial droop, no change. 1 or 2 points for arm drift. So some patients, you pick up their arm, falls immediately. That's a fast drift. Other patients are just a little bit weak, like this, that's a slow drift. 1 point for a slow drift, 2 points for a fast drift. And the third one is grip strength. So normal grip, no points. Weak grip, 1 point. Paralyzed, not able to grip, 2 points. This also avoids some of the problems with speech. For instance, if you are picking up a patient that is Vietnamese, you can't tell if their speech is better or worse. Or patients who are having trouble because of some other reason, or you can't really assess their speech very well. This leaves it out, and it's a little more sensitive. So if 4+ points, so facial droop, a rapid arm drift, or a weak grip, 4+ points, the likelihood of stroke is greater than 85%. This is extremely powerful. And this is something that, anybody can do this test. There's not a real steep learning curve here. We all know how to assess for drift. We all know how to look for facial droop. We can all test somebody's grip. And just that simple information, you can triage these patients to get to the right stroke center faster. You can have that impact on outcomes that we see. And a huge part of it is that pre-hospital care. So again, clot retrieval works. Timing is everything. And identifying stroke in the field is the first step. And then the next step is bringing patients to places that can actually do this work. And so I'm going to talk about high volume stroke centers. What makes a stroke center a stroke center? Well, there are a variety of different ways that people can designate their hospitals as stroke centers, but the one that is the most universally understood is the Joint Commission, or JCO, which we all know. But they have a series of guidelines that designate 3 different levels of stroke center. So one is an accreditation. So you just basically say, yeah, we can probably take care of stroke. It's like very, very straightforward. You don't have to prove the whole lot of infrastructure, like maybe you have a CT scanner, Then there's primary stroke center designation, which is, I'll go into the details, but is a little bit more involved in terms of the personnel and equipment available. And then there's comprehensive stroke centers, which is the A+ gold medal highest rating. And I'll get to that. So there are differences between these. There are big differences between accredited stroke centers and everything else. And then there are differences I'd like to show you about the difference between primary stroke centers and comprehensive stroke centers. And I have an ulterior motive that I'll get to in a little bit. So there's a variety of benchmarks that the Joint Commission uses to assess stroke centers. And one of them is, do they have a dedicated stroke unit, meaning a place where patients can go, that beds are just reserved for them for stroke. You're not going to put an orthopedic injury in there or something like that. Primary stroke center, designated stroke beds. They say, yeah, we've got some beds. Comprehensive, dedicated neuro ICU beds, 24/7, 365. We never go on divert. We're always happy to take the patient. We'll put other patients in the hallway, okay? So that's a big difference between primary and secondary. Diagnostic testing, primary stroke center, CT, MRI, labs, sure. Comprehensive stroke center, CT, MRI, labs, catheter angiograms, 24/7, 365. And when I mean 24 hours a day, I mean getting me up at 2 in the morning to do an angiogram on one of these patients, which I'm happy to do. That's one of the big differences is the guarantee. And the Joint Commission just did their certification for us again here. And they actually looked at our call schedule and mapped out every single day to make sure there was somebody on call just for stroke only. So that's a big deal for them. Stroke neurology personnel, primary stroke center, in person, or one of those little surrogates like from Arrested Development. Comprehensive stroke center, yeah, people are laughing. Okay, if you don't know, you should check it out. Comprehensive stroke center, in person, neurology, 24/7, 365. We have 8 dedicated vascular neurologists who have advanced fellowship training just in stroke. I mean, these are people, this is what they eat, sleep, and breathe. So that's a big difference between the two. Neurosurgery personnel, not to brag, primary stroke center, they have to guarantee neurosurgery personnel available within 2 hours. Okay. Not so helpful when talking about a stroke. Comprehensive, neurosurgeon immediately available, 24/7, 365. There's always somebody here. There's actually multiple people who are usually here. There's always somebody within a few minutes. I live just down the street. So, big difference. And treatment capabilities, IVTPA, endovascular treatment available. They don't have to specify to get primary stroke center certification when they're available. Friday night, Christmas, maybe they're not available. Comprehensive stroke center, endovascular and surgical treatment of stroke and aneurysms available 24/7, 365. Again, this is apparently what we do because we love it. So this is a big difference as well. And finally, clinical performance measures. So in a primary stroke center, there are 8 quality assurance measures: door to CT time, patient outcome, guidelines, these sort of check the boxes sort of things. Comprehensive stroke center, we're overachievers, 16. So big difference, but does it improve outcomes? Nobody cares if you have a little fancy seal on your flyer or whatever, or put something out in the hallway that gives you a gold star if it doesn't really help patients, right? Nobody cares about that. I don't. So does it really improve outcomes? Well, in a study of 442 stroke patients in multiple hospitals in New Jersey, about half of whom went to comprehensive stroke centers and half of whom went to other stroke centers, 65% more likely to have a good outcome at a comprehensive stroke center. All of these extra things that JCO makes comprehensive stroke centers do, they have a real effect on patient outcomes. Patients that get there tend to do better, right? Which is what we care about. And what if it's not an ischemic stroke? Maybe it's a brain tumor, hemorrhagic stroke. You know, comprehensive stroke centers are required to have neurosurgical management availability and personnel for these sorts of things as well. The most likely stroke mimic that you'll see in the community, so a patient who passes that LAMS test, but is not one of the 85% that has a stroke, is going to be most likely a seizure. And that could be from a tumor or hemorrhagic stroke. And we do everything with that too. We can deal with that as well. In fact, some of the same personnel are involved in that treatment. So even if it's not an ischemic stroke, bringing a patient to a high volume stroke center ensures that even a stroke mimic can be dealt with appropriately. So in a 16-year study of a lot of patients, 37,000 patients with hemorrhagic strokes, there was a 27% reduction in deaths in patients treated at a comprehensive stroke center. So even if we get the diagnosis wrong, and not really wrong, but there are things that look and act like a large vessel occlusive stroke that are actually things like hemorrhagic stroke. Comprehensive stroke centers, high volume stroke centers, these patients still do better because all the personnel infrastructure that are there to deal with ischemic stroke, we can translate to other stroke mimics as well. So it's still useful. So here's where we get to brag a little bit. So HARBORVIEW is the first and only comprehensive stroke center in Washington State. So you got to drive all the way to Oregon if you want another one. There are many primary stroke centers around in town and elsewhere, but we're the only comprehensive one. So what happens when you drop a patient off at HARBORVIEW to have their stroke treated? Well, it looks like this, but you can kind of think about it as like this side of the boarding area. You know, I don't know if you guys have the luxury. I'm always in this line for some reason, in the middle seat, but there are other people who get to go in that line. And that's what a stroke really is. The stroke code, so you radio in, you say, I've got a patient with a suspected stroke. I hear about it before you even get to the hospital. And in fact, a bunch of people hear about it. Techs hear about it, nurses hear about it. We have techs 24/7, 365. People running the angio machine, people who are dedicated to things like cardiac PCI as well as stroke, that this is what they do, and there's always somebody here. They're alerted, hey, there's a stroke coming in. So they're already knowing, we're getting the room ready, we're talking anesthesia, I'm, clearing my schedule, whatever. A neurologist is in the emergency room as the patient is brought in. So you don't have to wait around 2 hours. You've got somebody who's physically there, this is their job, they're sitting next to the patient, quarterbacking stroke care. You may drop them off, they're gonna get a CT scan, I'll show you our numbers extremely quickly to tell us what this is. And there's a radiologist sitting right there who's gonna review the CT scan while it's happening. So no minutes, no seconds lost when time is brain. Just like a heart attack, right? It's the same thing. And the decision for IV TPA or endovascular treatment happens very quickly. So when you bring somebody in, I know that HARBORVIEW is thought of as just a trauma hospital, and we do trauma really well. But this is a separate sort of fast lane. If a patient has a stroke, you just watch, it's like the Red Sea parts and everything just happens. And these patients go through incredibly quickly. It's down to a science. We've got benchmarks. We have all this stuff that we have to do to be a comprehensive stroke center. They get us really good at these things. So the workflow is so fast. When you drop a patient off, it's almost like they don't stop moving. They just right to CT, down to angio, like they never actually get a chance to settle in, which is good. So how fast are we? Well, this is a kind of a busy graph. I want you to ignore the bar graph. That's the number of cases. And just look at the lines here. And on the left side, you can see the time in minutes. So this is the door to CT scan. So you drop the patient off in the ER. And these are the most recent data we have for HARBORVIEW. How quickly do they get a CT scan? So obviously, lower numbers are better than higher numbers. So in the dark time here, median time for intervention, these are the patients where a suspected large vessel occlusion was occurring. You can see that here's the quarters. So last year, 2014, now October, December, January, March, April, and June. So this is the most recent one. You can see that median door to CT time, 8 minutes. So pretty much about as long as it takes to get the patient to the CT scanner, put them on the scanner. We don't mess around, right? They're not sitting around getting labs, waiting for somebody to see them, waiting for the neurologist to finish the last hole of his golf game and come in, right? We're there. We're not wasting any time. So what else? Well, how about TPA? So this is a big deal for stroke centers and for nationwide. For eligible stroke patients, again, ignore the columns. This is by year from 2011, 2012, 13, 14. Here's first and second quarter of 2015. What you can see is these are the percentage patients who get TPA within an hour of hitting the door. This line is for all comers, anybody who may have a stroke, maybe we're not sure. This line is for patients where we're pretty sure even before they get to the hospital, they probably have an ischemic stroke. And you can see that we're at 100% for the last 6 months. And this was the guidelines were basically introduced around here. So these are patients where we're giving them every possible chance of getting the medication they need to bust up that clot. So door to CT time, extremely important, 8 minutes. Door to TPA within 60 minutes, 100%. So I think we do a pretty good job. Can't get much better than 100%, although my parents would always tell me you could. And then lastly, so this is ischemic stroke door to treatment. So what we do when we bring the patient to angio, put in the catheter, go up and suck the clot out. And you can see here, compared to 2013 when there were still trials going on, here's the line we care about. And the goal is here is at around 90%. And now we're at 100%. So our infrastructure for stroke is now so fast that between the patient hitting the door and getting their angio started within 90 minutes, we capture every single patient. We're very proud of this because it's hard to do. But again, it's dedication of personnel, having personnel ready, having the infrastructure there, and treating strokes differently than your average, I fell on the ground and hit my head. This is a totally different emergency room experience for these patients. So 100% eligible cases, clot retrieval in less than 90 minutes. So that's what we can get from here to here, right? So in summary, clot retrieval works, but the timing is everything. And identifying stroke in the field plus high volume stroke centers is better outcomes, which is what we all want for our patients. So with that, I thank you for your time and answer any questions that you have. It's always good to end super early, right before lunch. Otherwise, people start to get restless. I know I.
Okay. Jamie Emmert from King County EMS. I have a question about your code stroke activation. What criteria need to be met in order for your internal code stroke process to be activated?
So there are 2 steps to our stroke code. One is the possible and one is the very likely stroke code activation. So really, one is a pretty inclusive stroke code level, we call it level 1, I think. And that is, patient has some neurological deficit that is suspicious for acute onset that could be ischemic stroke. So, grandmother, grandfather has been having trouble moving his right arm since a few hours ago. That's something that's very suspicious for ischemic stroke. The level 2, I think we call it here, stroke code level 2, that's a very likely story. So somebody's evaluated that patient in the field as clearly a weakness. It's one side, not both. They don't have some other problem going on like a history of seizures. This is a highly suspected case, or the patient has imaging in the hospital or another hospital that shows that there's a clear vessel occlusion, and that bumps up the level of acuity. So a stroke code, like type 1 stroke code, everybody gets the page saying, hey, there's this thing out there, get ready, but it may not really be the case. We'd rather be more inclusive than less. So we'd rather be ready and not have to do anything than be scrambling to do something at the last minute. And then if it's bumped up to that second level, that means we're pretty much going to do an endovascular procedure. So we're opening up the kit, we're getting the room ready. If there's something scheduled, we're clearing the schedule, we're making sure that everything is lined up, getting anesthesia, etc. Does that answer your question?
Yeah.
Other questions? Yes?
So a lot of these folks are working for EMS agencies that are not in the city of Seattle, but are in the periphery of King County or even in different counties.
Yep.
And I know an issue that concerns many neurologists is the concept of bypassing a hospital that could start TPA in favor of a longer drive to a hospital that can do an endovascular procedure. Sort of want to get your thoughts on where do you think the tipping point is?
It's great. I really wish that I knew, and there's actually an email thread between a variety of the stroke and endovascular providers all throughout the western part of the state that's ongoing like now, like this morning. Like I probably have an email now that I haven't seen yet talking about this, and it's exactly that question. We know that for patients who are really far away from a stroke center that offers endovascular, just getting them to a place that can do TPA is the right thing to do. We know that when patients are right next to something like a comprehensive stroke center, like HARBORVIEW, they should really be brought here because we have the capacity to do it. But that time of, do we drive right by a place that does TPA but not endovascular in favor of driving a little further and the possibility that we go up and take the clot out? I don't think anybody knows the right answer. I'm guessing, based on the conversations that we've had, it's probably going to end up being something like, if it adds another 15 to 20 minutes to the transit time, that we may do that in favor of bringing to a place that has endovascular treatment. But that's not set in stone. We're working on that. It would be a short amount of extra time. We're not asking people to travel an hour out of their way, but if you're reasonably close, then it's usually better to bring patients to the higher level stroke center, because if you really suspect they have a large vessel occlusion, like that fulfill those criteria, then they're going to end up in those places anyway. And all you're doing, bringing them to someplace else, is just kind of taking up a little bit of extra time. But in terms of the actual timeline, what you guys will do when you're driving, we'll see. That's something that we'll probably hash out in the next probably few weeks. So it's a good question, but I don't know.
What about the patients that fall outside the TPA window? It seems like there's a lot of discussion with the hospitals outside of the city here that they still want those patients to come there, obviously, because it makes them money.
Right.
But they can't do anything about them but transfer them to you. It seems like those patients should maybe be coming direct.
And I personally couldn't agree more. So the real issue is the patient who's past the 4.5 hour window, or will be by the time you get there. What's the point of bringing them there if they're not going to give TPA? And I personally, I agree with you. I don't think that patients should be brought to a hospital that won't have anything to offer except a CAT scan and then a phone call to us. It doesn't really make a lot of sense. There are a lot of competing interests as to why different hospitals want different patients, and obviously there's an incentive for patients to come to closer hospitals for patient volume and things like that. But personally, I think that those patients should be straight to at least a primary stroke center. If they're within city limits or close by, they should be brought here. We're the only comprehensive stroke center. They should just be brought here because we're the only place that can guarantee 24/7, 365 endovascular. And if you're outside of the 4.5 hour space, that's the only thing that's going to make a difference for that patient. So there's just no reason to bring them anywhere else. But in terms of elsewhere in the state, knowing where a primary stroke center is, this is going to be a better bet than bypassing a little smaller community hospital is probably the right call for these
I
patients.
think some other discussion is that we may not be able to tell the difference between an ischemic and a hemorrhagic stroke, and therefore they could maybe potentially take care of the hemorrhagic stroke there instead of bringing him all the way here.
As another great point, my two reasons why I still think that bypassing is the right thing. One is if you're doing the triage in the field, you're so much more overwhelmingly likely to catch an ischemic stroke than a hemorrhagic stroke. If you're just playing the odds, it's just a better bet. Number two, hemorrhagic strokes, they do better at comprehensive stroke centers than they do at other centers anyway. And number three, I can tell you from personal experience, when you bring that patient to a smaller hospital, what are they going to do? They're going to do a CT scan, and then they're going to call me and say, hey, we got this guy with a brain hemorrhage I don't feel comfortable managing, can we send him to you? So really, this is sort of not very beneficial to patients if they are outside of the window for TPA. If they're within the window for TPA, then it's a different sort of discussion. We talk about how much extra time are we willing to tolerate. But otherwise, no, I just don't see much of an advantage of bringing those patients to a regional hospital that can't do anything for them. Because all they're going to do is call us and send them. Other questions?
So it's my understanding that if, and I've had several patients do this, awaken from sleep in the morning with a full-on stroke, it's pretty easy to diagnose, and they're disqualified. Now, my thinking is they got about a 50-50 chance of being inside of that 4-hour window. And if it was me, I'd say take the best shot and see how it ends up. I don't think it might get better.
Right.
So is there an avenue for that? You know what
Yeah.
I'm saying? Because I feel really badly. I just started 15 minutes ago.
Totally. So, okay, you guys have a really sophisticated understanding of these issues because these are all the things that we don't have answers for. I thought we had an agreement here. There is an ongoing, or there's going to be a trial starting to look at wake-up strokes. It's extremely controversial. Reason being, there are some substantial number of patients that will not get better no matter what you do, and you have no way of knowing if it started 15 minutes ago or 8 hours ago. Most neurologists would not give TPA in the setting of a wake-up stroke because it's off-label, and the risk of hemorrhagic transformation is too high. So most neurologists, I'm not a neurologist, so I don't want to speak for them. I would say the majority of neurology opinion is that they would not give TPA. For when I see a wake-up stroke for endovascular treatment, there are some advanced imaging techniques that we can do that I think we had here.
The first few slides.
That first few slides, so way back when we talk about CT perfusion. So here's an example of, let's see here. So here's an example of imaging where if we saw that there was a big area that was not getting blood flow fast enough, but the tissue was salvageable, I would take the patient for endovascular intervention at 12 hours, because this tells me, anatomy is one thing, it tells you that blood vessels cut off, but that doesn't tell you how the brain is responding. And to me, this patient, if this was a patient who woke up from stroke, I would absolutely take this patient for clot retrieval immediately. I would treat it as if it just happened, because this tells me there's something real there. And Conversely, if you do the CT scan and the CT perfusion and it shows that this part looks like that part, there's nothing to be done. That patient's already had a completed stroke, that tissue is already dead or mostly dead, and so taking out that clot is not going to help the patient at all. We have the ability to do these perfusion scans anytime, 24/7, and that's what we use for our triage. So for wake-up strokes, you know, it's still controversial, so I don't want to speak for the neurologists in general. My understanding of the literature is that those patients are more likely to be a candidate for endovascular treatment than for TPA. So again, you're going to be wanting to look for centers that are close by that can offer clot retrieval. Question right behind you.
Are there any other hospitals that have that scan capability in the state?
I would guess yes. I don't know which ones. I'm sure that some other places in Seattle that have advanced imaging do. I'm not sure about south and east of here. I can find out and let you guys know. And then another thing is just whether or not people use this information. A lot of places may have the capability, but they don't use it as a method of patient selection. This is really kind of at the cutting edge of stroke treatment, is using perfusion imaging and advanced imaging to make these decisions. And that's not something that is done everywhere, even places that have the right CT scan. Yeah.
A couple questions. Number one, is there any imaging that can be done, or does this involve using iodine for patients that are allergic to iodine?
Really, another great question. Thank you. I spent a lot of money here bribing people to ask these great questions, and it's really paying off. The short answer is yes. There's a special type of MRI that it can be done without iodine contrast that we do here that gives us this image without any sort of contrast, so patients with a contrast allergy. We are just implementing that in terms of having this available 24/7. It is something that we can do, and for those rare patients that have an iodine allergy, we can actually accommodate that. I don't think there are any other places in the state that are really doing that or looking into that, because it's a pretty, I mean, we have to, I guess the guy, one of my colleagues, Dr. Andre, who's a neuroradiologist here, he wrote the code himself to get the scanner to do this thing. It's kind of crazy. He's like a mad scientist. But yeah, so these are things that if a patient had a contrast allergy, we could do. In reality, what we usually say is, they have a contrast allergy, let's give them some steroids, let's give them some Benadryl, and let's just go. Because even if we got the scans without contrast, to do the endovascular treatment, you have to use contrast. And so we basically just try and mitigate the risks and risks and benefits.
The other question is, what are the options for a hemorrhagic stroke?
Great, so another good question. If a patient is a hemorrhagic stroke, these are more challenging patients to treat because really if you look at any of the data, we haven't really found anything that truly helps them. Patients with a large hemorrhagic stroke, we can do an emergency surgery to remove the blood clot. Smaller hemorrhagic strokes, we usually control the blood pressure and mitigate the damage. We're about to start a study here that uses an endoscopic, very small burr hole, very small endoscopic approach to removing the blood clot under direct visualization. So we'll be enrolling patients in that within the next few months. That's, again, a very cutting edge. It's into the auspices of a randomized trial, multi-center trial of 35 centers around the country and in Canada that's looking at a super, super minimally invasive way to remove hemorrhagic stroke. But it doesn't quite have the same outcome lift that this does.
Understanding that the time, understanding that the time is your treatment priority. In the city here anyway, we've got both BLS transport, ambulances, and ALS transport medic units. Both got lights, both got sirens, we can get here fast.
Yep.
Is there anything in this setting that would differentiate other treatment priorities that would change it from a BLS to an ALS transport where you want like elective innovation or medicines or anything that would properly prep both you and the patient upon their arrival?
So this is a great question because if it were up to me, I would have everybody just seen by ALS. But no, it's only because it's not because BLS is any worse or better. It's because ALS, when they come here, they're treated slightly differently. And this is a problem that we have that everybody has on any hospital end, which is BLS is considered not as important, but stroke is a BLS diagnosis most of the time. So this is actually extremely important. And one of the ways that a BLS provider can improve the outcomes of the stroke patient rather than just handing off to ALS, is if we do this pre-hospital scale, this LAMS or FAST exam, you say, look, I have a very, very high suspicion that this is a large vessel occlusion. We here take that very seriously. So I think in terms of handing off a BLS to an ALS patient, this is a difficult issue because it does take a little extra time. Resources are stretched. ALS people are responding to the horrific traumas or things like that, and we can't do that for every stroke, nor should we. The stroke can be a BLS diagnosis just as well. But for certain cases, I think having an extra set of eyes, if we're not sure, having a BLS provider call an ALS if somebody is on the fence or you're not sure about the pre-hospital assessment, this could be useful. Or if a patient seems like they're going downhill fast, then electively intubating them in the field is obviously going to be beneficial for the patient. Does that answer your question? I wish I had a better way of triaging, but I don't think BLS should be cut out. I just think that we need to be, there's no reason that BLS can't be at that higher level of diagnosis to be able to say, look, clear the decks, we've got a stroke coming in.
To piggyback with that, we just brought in one to Swiss Cherry Hill yesterday, actually, a 33-year-old guy. And they specifically asked us to have 2 lines, blood's drawn, and a blood sugar. So they had a couple things taken care of because they do TPA through one line and they do everything else through the other. So that's, we'd like to know also what you exactly want us to have.
So obviously with anybody with we're suspecting an acute stroke, at least 1 if not 2 large bore IVs are going to be critical. And we can start them really fast here, but if you can start them in the field, so much the better. Labs, I'm actually not sure if this is something that maybe Dr. Carlbaum, do you have any insight into when patients get labs in the field and brought in? I mean, obviously that would be helpful because there are some basic coagulation labs that we have to have. So like a blue top that tells us the patient doesn't have a bleeding diathesis. This is probably the only thing that personally that I would really care about before I do a stroke intervention, just so you know that there's not some risk for bleeding. In terms of the pre-hospital care, I should probably ride around in an ambulance to tell you.
Similar to ischemic stroke, do you have a sweet spot for hemorrhagic stroke if blood pressure, if we have any control over that?
Yeah, again, I think the parameters are going to be somewhat similar, somewhere in the 140 to 180 range. Avoiding hypotension is really important. The extremes of hypertension are going to could cause secondary bleeding. It's a pretty wide window, and you'll see some patients that you're struggling just to keep them not hypotensive with pressors, or other patients who are at 220 that you're just struggling to get back down. But somewhere within that, a little bit higher than normal 180 range, but avoiding that hypotension for both hemorrhagic and ischemic, you really can't go wrong. Other questions? Tom?
So I think, thanks for a great talk. If you weren't from HARBORVIEW, I'd ask what your allegiances were. It's not obvious in your talk at all.
I will tell you that, thank you for that. I'm not even-handed. I think that everybody should be brought here. But that's just because this is what I like doing, and I want to be busy, and I think that the patients get better care here, and I would want care here. But I think the data show that the comprehensive stroke centers do better. Anyway, I don't mean to hijack the question.
Like I said, it's good to know. I think that for EMS, it's more nuanced than just driving by, because as you point out, you can get in the door and then different things happen at different institutions. And so this idea that you get a CT scan so quickly and that you get lytics when you're supposed to get lytics, I don't think we have a good handle on which hospitals do a good job. And I know we're working on getting that information, but that's important. It's not just time past the hospital, because I think hospital quality of care is likely different across the county or across the state. And then another comment is this number needed to treat of 6 is pretty remarkable, because if you look at medications we give patients to prevent stroke or prevent MI, when you're in the hundreds, right? You got to treat hundreds of patients. And if you talk about acute coronary interventions for MI, I think you're talking about 10 or 12 or 15. I don't know if Kunchuk's still.
Yeah, he's right behind it.
But
he's not
I think that's right. So now you've got something here that's like 6.
Yeah, so we're better.
We're approaching.
I'm sorry.
You're so good.
Yeah.
Well, I mean, not as good as the medics are in resuscitation, where
no, that's 2,
right? You gotta save 1, right? So I think.
All right, you guys win.
Yeah, but along those lines, I guess I'd be interested to trying to make this decision about, well, how important is TPA in trying to determine whether we go further to find an institution that can provide this. So if the number needed to treat is only 6 for this therapy, what is the number needed to treat with TPA?
Well, I can't tell you the exact number. I know it's pretty low, but you have to remember that this is for patients with diagnosed large vessel occlusion. So you're not quite talking about the same patient pool. And only a subset of patients with a high stroke score, like a LAM score, are gonna have a large vessel occlusion that's amenable to endovascular therapy. TPA is still the standard of care. It's still, if you talk about the most amount of lives saved, it's still a bigger pie than endovascular treatment. And if you have the choice of getting a patient to a hospital within the TPA window or driving an extra hour to get to a hospital that can do endovascular, you ought go to the TPA hospital because you're more likely going to have if you play the odds are higher. If you have a choice between the two, or like we were talking about the sweet spot of a time limit, a little bit of an extra drive, then I think bringing patients to a place with endovascular treatment, even if you burn 10 to 15 minutes, is worth it for the patient. But because it is a low number to treat. But overall, we can't just centralize all stroke care as much as we might like for places that just do endovascular, because we're going to cut out patients that are going to lose that should just get TPA. And that exact number, that time limit, that 15 to 20 minutes we were talking about, we're working on that now. We should have some guidelines shortly. Anything else? So I'm just going to put up my email address here so everybody can. So if there's any questions, email me, call me. I'm always around. You'll find me here, but happy to answer any questions offline as well. Thank you.
Perfect. All right. Thank you very much.